Assalamu alaikum everyone. So today we'll be discussing the final proof written questions on the musculoskeletal system. The plan will discuss the questions, the final proof questions, written questions. I have the questions written down here, and so let's start. So firstly, we're going to start with the introduction of arthritis. So arthritis, maniki. So arthritis is the inflammation of the joint. Okay. So arthritis means what? Inflammation of the joint. But don't confuse the term with arthralgia. So arthralgia is different term. Arthralgia means it is the pain in the joint. Don't confuse these two terms because it is if you like sometimes you guys use interchangeably, but it's a different term. So arthritis, they discuss about, they ask about the types, like monoarthritis. We have three types of arthritis. One is monoarthritis, another one is oligoarthritis, and another one is polyarthritis. So monoarthritis means if you have involvement of the one joint group, then it is called monoarthritis. What? Involvement of the one, not one joint, it involves one joint group, right? Then oligo হচ্ছে কি 2 to 4 joint group involvement থাকবে, ওটা হচ্ছে কি oligoarthritis. Another one is oligo, that is 2 to 4 joint. If you have involvement of the more than five or more than five joint group, then it is called what? Polyarthritis. It is polyarthritis. So these are the types. So monoarthritis first, let's discuss about the polyarthritis. So whenever the polyarthritis comes in your mind, so you have to think of three things, always three things: rheumatoid arthritis, SLE, and viral arthritis. These three things are the only things you need to remember about the polyarthritis part. So it is all about polyarthritis. So here the question asked about the 30-year-old male presenting with monoarthritis. So monoarthritis, we have like a differential diagnosis. So differential diagnosis for monoarthritis. Monoarthritis is if it is acute onset. Suppose the patient has like the monoarthritis means what? Involvement of the one joint, like if the patient presents with a knee joint pain or something like that. So acute cases. So the acute cases is usually caused with gout. We have septic arthritis and trauma. So these are the only three things you need to know. So chronic causes only one, that is osteoarthritis. So these are the differential diagnosis for monoarthritis. So here they ask you about how do you investigate this case, right? So you have to exclude, like you have to go to the definitive, like differential diagnosis management, right? So how can you differentiate between these differential diagnosis? So first thing we're gonna do is the arthrocentesis. Arthrocentesis means what? Tapping out from the joint fluid. Joint fluid আমরা বের করব. So what is it called? Arthrocentesis. So we have the different like the lab values for this. So gout, trauma, and so we have the first one is the degenerative changes, right? Degenerative disease such as osteoarthritis. So osteoarthritis in the arthrocentesis, the cells, we typically look for the cells, polymorphonuclear cells. So in osteoarthritis, the cells are below the range of the 5,000 এর নিচে থাকলে আমরা কি বলবো? এটা osteoarthritis এর ফিচারে যাইতেছে. So if the cells are between the 5,000 to 50,000, so if it is between 5,000 to 50,000, we think it is a case of the any case of the gout or any case of the inflammatory arthritis like rheumatoid arthritis. These are the differential diagnoses you need to think of. If the cell count in the arthrocentesis is more than 50,000, then we go for the diagnosis of what? Septic arthritis. So this is how you can differentiate between these three from the arthrocentesis. Another thing you can do is the X-ray. So you do the X-ray. So in the X-ray, so what is the X-ray finding in case of the gout? So important, gout এর মধ্যে কি X-ray finding পাবো আমরা? We find the punched out erosion with rim of cortical bone. So specific punched out erosion with rim of the cortical bone, that is in the gout. So septic arthritis in Madhya, we have in X-ray we have normal joint space, but there is a soft tissue swelling there. So there is a soft tissue swelling because it is the infection. So there is a adjacent soft tissue swelling. So in case of the trauma, you can find like a fractures like hematoma, like okay. And in case of the osteoarthritis, so osteoarthritis, there is specific features in the X-ray, that is the narrowing of the joint space and the osteophytes and narrowing of the joint space. Okay, so usually we only go for these two things, the arthrosynthesis and we go for the X-ray of the involved joint. So this is how we can differentiate like the monoarthritis, differential diagnosis of monoarthritis. So see at the question number 2. So question number 2 is asking about the difference between the inflammatory and the mechanical arthritis. So what is the difference? So inflammatory arthritis, always remember that whenever you're doing rest, the inflammatory arthritis, pain of the inflammatory arthritis rises. And whenever you exercise or do something like mobilize your joint, the pain decreases. But in case of the mechanical arthritis, if you do more work, the pain will go worse. And if you do the rest, the pain will goes down, right? So these are the important. And temperature over the joint is increase in the inflammatory arthritis, whereas in case of the mechanical arthritis, temperature over the joint is normal. In the case of the inflammatory arthritis, there is crepitation. If you like the usually not, we do not look for the crepitation, but crepitation is the sound that whenever the movement, there is a cracking sound. That is crepitation we see in the mechanical arthritis, whereas we do not see in the inflammatory arthritis. So what are the examples of inflammatory and mechanical arthritis if you are thinking? So inflammatory arthritis are usually rheumatoid arthritis, SLE, ankylosing spondylitis, all the seronegative and seropositive arthritis. And in case of the mechanical arthritis, there is usually osteoarthritis. These are the mechanical arthritis. Okay. So question number 2 is to discuss. And then question number 3 is asking, how do you differentiate between the inflammatory and mechanical back pain? So it is same as the question is same, but the answer you have to write a little bit different. Like the inflammatory reste barbe exercise করার পরে কমবে, whereas it is opposite in case of the mechanical lower back pain. There is warm joint, right? Warm joint থাকবে কোথায়? Inflammatory arthritis. And another thing is the inflammatory arthritis, usually it is associated with the systemic features, like in case of the rheumatoid arthritis as SLA, like there is a malar rash, discoid rash, rheumatoid arthritis, there is diffuse involvement of the other organs also. So inflammatory arthritis is usually associated with what? It is associated with systemic features. So these are the difference between the inflammatory and mechanical back pain. So another thing, so low back pain. So we'll discuss in detail about the low back pain. So what are the causes of low back pain? So low back pain cause ki kya hai? Low back pain. So I hope you can see this slide. So low back pain cause hochchhe 4ta. So there are 4 causes of the low back pain. So one is what? One is musculoskeletal cause, another one is inflammatory cause, another one is malignancy, another one is infectious. So you can remember MI, musculoskeletal, infectious, inflammatory, and malignancy. So if in Viva they will ask about what is the most common cause of the back pain. So the answer should be a musculoskeletal. Mechanical part is the most common one. So mechanical cause of the lower back pain is the most common one. So what are the things you need to, like the causes of the in musculoskeletal? So in musculoskeletal, there is maybe a mechanical cause, like muscle strain, spasm after you get like a heavy lifting or something. So that is in the mechanical. So if there is a hernia of the nucleus pulposus, as you know, the nucleus pulposus is the middle part of the vertebral disc. So if it bulges, herniated nucleus pulposus. Another one is spinal stenosis. It is usually seen in older age, and the typical feature here is the patient pain is better with the spine flexion. So যখনই patient মানে extension করবে, the like the diameter of the spinal canal was decreased, so that causes the worsening of the pain. Another one is compression fracture, where if the patient has a history of the trauma and now presents with the back pain, compression fracture, right? Then inflammatory causes, we have the seronegative arthropathies like rheumatoid arthritis, reactive arthritis, and ankylosing spondylitis. These are the part. And in the malignancy, most commonly the prostatic cancer, usually the prostatic cancer. Others are like the breast cancer, lung cancer can also be the causes. Another one is the infectious osteomyelitis, discitis, abscess, any infectious cause. So these are the causes of the back pain. So if I'm gonna revise you this slide, so you think of the four things about the back pain, right? One is musculoskeletal problem. In musculoskeletal problem, there are four things. One is mechanical. In mechanical, there is a history of the heavy weight lifting. And in the nucleus pulposus, like the herniated disc, there is a features of the the neurological deficit. There is a radiculopathy in the lower limb. There is a shooting sensation of the pain. So it is in the nucleus pulposus, herniated nucleus pulposus. And in the spinal stenosis, it is usually in the old age. The patient pain will be usually gets better on flexion. And another one is a compression fracture. There is a history of the trauma, right? These are the four things. And in case of the inflammatory, there are seronegative arthritis. In case of the malignancy, the prostatic cancer, breast cancer, infectious like osteomyelitis, discitis, or abscess. So these are the causes of the lower back pain. So how do you evaluate a case of the lower back pain? Whenever the patient presents to you as the low back pain, you have to exclude the notorious things first, like the serious causes first. So what will you do? You will ask for the red flag signs, or is there any signs of the cord compression or sciatica? So these three things will indicate that the patient is having the notorious cause. So what are the red flag signs? So red flag sign is more than 50, nighttime pain, constitutional symptoms, history of malignancy, trauma, IV drug abuse, infectious risk, more than 1 month with no improvement. So this all indicates of the notorious pathology. First, we have to exclude this. Then we have to ask, is there any features of the cord compression? So cord compression feature, whenever there is a cord compression, there will be feature of the cauda equina syndrome. So cauda equina syndrome will usually present with what? There will be a saddle anesthesia. Saddle anesthesia means what? There is a loss of sensation around the perineum and the inner aspect of the thigh. So that is saddle anesthesia. That is the symptoms of the cauda equina syndrome. So there is usually history of the what? The patient will have incontinence of the bowel, as there is a loss of the anal tone. So this will be we have to exclude this first. So if there is no symptoms of any red flag signs or any sciatica or any cord compression, we can go for the conservative therapy. So what does it mean by conservative therapy? Conservative therapy means what? We use the NSAIDs. So we use occasional use of the NSAIDs, and we tell him to bed rest for a while, minimizes excess, minimizes workload, So that types of thing is a conservative therapy, 4 to 6 weeks. So if the patient complains to you about the red flag sign, any of these low red flag signs, or the patient complains of the shooting sensation, so in that case, we'll do back X-ray and the erythrocyte sedimentation rate. So if this X-ray and ESR is normal, we go for the conservative, and if the X-ray and the ESR is abnormal, we go for MRI. So ultimately, we have to do the MRI. Okay. So whenever the patient presents to you, the most investigation of the choice is MRI. So investigation is the ultimate one. So if the patient complains with the cord compression sign, as I have said, discuss about the saddle, like the cauda equina syndrome, then we'll directly do the MRI. Then we'll know the cause, and we can separate what treatment to be given. Okay. So this is the evaluation of the acute low back pain. You're gonna see multiple patients coming with the low back pain, in your chamber or in your home, either you're suffering from the acute low back pain. So this is how you will evaluate a case of the low back pain. This is the very most common, common disease. So as I've said, acute lower back pain, what is the conservative therapy? Conservative therapy means the maintaining the moderate activity and giving the NSAID and acetaminophen. So to help improve the the pain, right? So we can use muscle relaxant also. So we generally use muscle relaxant, spinal manipulation, and brief opioids. They do not have the significant, changes like the effectiveness. So we usually say minimize exercise, NSAIDs for the pain, and muscle relaxant. These three things for the acute back pain. So if someone is having a chronic back pain, the patient is complaining of the back pain from years to years. So in that case, the main thing is exercise. Okay, the main thing is strengthening, muscle is strengthening, exercise. So chronic, you always think exercise. So chronic exercise. So chronic exercise. So in case of the like exercise মধ্যে করার পরেও মানে কোনো সময় মানে পেশেন্টে occasional pain থাকতে পারে, so in that case we intermittently use the NSAIDs. Okay, we intermittently use NSAIDs like naproxen, aceclofenac, diclofenac in that case. So in chronic pain we can also consider using the tricyclic antidepressants like amitriptyline. So this has shown to be effective in case of the chronic pain. Okay, this helped in the improvement of the symptoms. So this is the thing. So acute low back pain, you think minimize activity, NSAIDs. Chronic low back pain, you think of exercise. Okay, this is about the low back pain. So here another one is a frozen shoulder. So frozen shoulder is actually a case of the like it is the adhesive capsulitis, another name of the frozen shoulder. So as you have already know from the term, so frozen means what? Frozen means it doesn't move, right? Shoulder means shoulder, we have shoulder. So shoulder that is not moving, we have the shoulder that is not moving, that is frozen shoulder. So frozen shoulder is also called adhesive capsulitis. So what happens in this disease is the humeral head is attached to the, so there is some kind of the inflammation process, and the capsule becomes inflamed, and the capsule becomes attaches like a gum to the scaphoid, glenoid cavity. So what happens? The shoulder movement is restricted. So patient will have shoulder movement is restricted. Usually the movement of the internal rotation and abduction is the first movement to be restricted. Okay, so remember this, internal rotation and the abduction is the first movement to be restricted. So in case of the frozen shoulder, so the frozen shoulder usually is associated with the people's having diabetes mellitus. So frozen shoulder is usually common in that cases. So the treatment for frozen shoulder, so you see any patients having the restriction of the movement, range of movements of the shoulder, you diagnose it as a case of the frozen shoulder. It is usually associated with the diabetes, and the mainstay of the treatment is exercise. Okay, the frozen shoulder, the mainstay of treatment is exercise and NSAIDs. Exercise and NSAIDs, but we can also give the intra-articular glucocorticosteroid injection to improve the symptoms. To fasten the recovery, we can also give the intra-articular glucocorticoids. So the treatment is exercise, and NSAIDs, exercise, NSAIDs, and intra-articular glucocorticoids. Okay, this is all about the lower back pain and the frozen shoulder. So let's move on to the osteoarthritis. So osteoarthritis is the degenerative disease of the joint, right? So there is a degeneration, the degeneration happens, and the bone will go against the bone, right? So what is the management? So the most important one is what is the management of osteoarthritis? So the osteoarthritis is very common in your home or in your family. You can find many patients having the knee joint pain, right? The obese patient who is having knee joint pain or has a history of the previous history of the trauma to the joint. So you'll find very commonly. So the line of management we're going to discuss now. So treatment হচ্ছে কি প্রথমে first thing is the non-pharmacologic দিয়ে শুরু করব আমরা। pharmacologic নন ফার্মাকোলজিক ম্যানেজমেন্ট হচ্ছে কি তোমার ওয়েট লস, প্রথমেই হচ্ছে কি ওয়েট লস করতে হবে আর এক্সারসাইজ, দিস ইজ দ্য ফার্স্ট লাইন। সো পেশেন্টে বলবো কি ইট ইজ ইউজুয়ালি কমন ইন দ্য ওবেস, সো উইল টেল পেশেন্ট টু লুজ ওয়েট অ্যান্ড এক্সারসাইজ। সো ইফ it is not resolved by this, we can use the pharmacologic, go to the pharmacologic, to the NSAIDs. Intermittent we can use NSAIDs like the aceclofenac, diclofenac, right? So after this pharmacologic management, also the patients does not improve, then we can go for the other drugs like topical NSAIDs, and there is another drug called capsaicin. Okay, capsaicin. And another one is intra-articularly we can give two drugs. Intra-articularly we can give two drugs. One is glucocorticoids. Another one is hyaluronic acid. So if the most of the patient will resolve by this, but it is a chronic pain. Patient will have chronic pain, chronic management. We have to go for the chronic management. So this is the mainstay treatment. Firstly, non-pharmacologic, we tell the patient to lose weight, exercise. If not, we go for the drugs such as NSAIDs, and if not controlled, we go for the topical NSAIDs, and we have another drug called capsaicin, or we can give the intra-articular glucocorticoid injection or hyaluronic acid intra-articular injection. If not, we can go for the chronic pain management. Okay, non-surgical candidate ক্ষেত্রে আমরা chronic pain management এর জন্য management করতে পারবো। আর কোন ক্ষেত্রে আমরা কি like the joint surgery, replacement surgery ও করব, but it is not the mainstay of the treatment. Mainstay of the treatment is non-pharmacologic and NSAIDs. So in your house or in your family, anyone suffering from the osteoarthritis, knee joint pain, like the patient is always, you tell them to lose weight and exercise, muscle strengthening exercise, right? And if not controlled, we'll give a short-term therapy with the NSAIDs. If not controlled, then we go for the intra-articular glucocorticoid or hyaluronic acid injection, or we can use the topical NSAIDs. Then if not, like if the patient is candidate for the surgery, we go for the surgical management, like the joint replacement and others. And if the patient is still not fit for the surgery, then chronic pain management should be done. So this is all about the management of the osteoarthritis. Now let's move on to the gout part. So gout, so in your final proof examination, the gout will be, the scenario would be like this. The patient, if the -year-old male patient is coming with the pain, swelling, redness over the first metatarsophalangeal joint, right? How do you diagnose this case and how do you manage this case? So usually the patient will present at the podagra. So what it is called? Podagra. So podagra means what? First metatarsophalangeal joint involved থাকবে আমাদের কি gout mainly acute case. So that is called podagra, right? So what is the treatment of the gout? The main thing is like the podagra আসছে patient, like আমরা কিভাবে treat করব acutely. So acute gout management হচ্ছে, where we can discuss the protocol here. So first thing is first আমরা ice pack দিব, okay, to like the relieve the inflammation. We'll give the ice pack. So ice pack দিব, তারপরে NSAIDs. So we give NSAIDs, and or we can use the oral colchicine. Okay, oral NSAIDs or colchicine. Okay, so this is the first line. Firstly, patient আসার পরে ice pack করে আমরা NSAIDs use করব or oral colchicine. If the patient does not resolve, we can go also for the oral prednisolone. Suppose the teacher can ask you like, what is the new type of therapy for this acute gout? What is the new drug we can use? So there is one biologic that has been recently added, biologic, that is canakinumab. So canakinumab. So this is the monoclonal antibodies that is recently introduced. So this is what we can do. So it has কি তোমার আমাদের first line management of the acute gout. So এখন আসো আমার chronic management কিভাবে করব? Suppose the patient is having gout, recurrent gout or anything. So patient is having more or 2 attack of the gout attack, or patient is having any evidence of the bone or joint damage, or if the patient is associated with a renal disease like nephrolithiasis. So what will you do? Will then treat as a chronic management. So chronic management আমরা কিভাবে করব? Chronic management এর জন্য আমাদের মাথায় রাখতে হবে, either this gout is overproducer or either this gout is undersecretors. So একটা আছে বেশি ইউরিক অ্যাসিড প্রোডিউস করে, একটা আছে ইউরিক অ্যাসিড ঠিকই প্রোডিউস করতেছে কিন্তু এক্সক্রিট হইতেছে না আমাদের রেনাল কিডনি দেখে. So we have to, so after like differentiating between those. So if the patient is overproducer, so in that case we'll give the allopurinol. Or if the patient cannot tolerate allopurinol, then we have another drug called febuxostat. If the patient is under secretor, then we can give the uricosuric drug that enhances the excretion, that is probenecid. So this is how you manage the gout. Okay. So another thing is how do you diagnose the case as a gout? So gout is the podagra feature near aspect, but what is the most diagnostic test like we use for the gout? So the diagnostic test is arthrosynthesis. So arthrosynthesis করব আমরা arthrosynthesis মানে joint fluid aspiration করব joint fluid aspiration করার পরে আমরা সেলসটা পাবো like the polymorphonuclear cells will be from the 5000 to the 50000 as I have discussed before, and there is a specific crystal monosodium urate crystal পাবো. So this crystal monosodium urate crystal is the negatively birefringent crystal. So they will ask negatively birefringent monosodium urate crystal. This is the diagnostic of the gout. So this is all about the gout. Now let's move on to the osteoporosis. So here you can see they ask about the case of the osteoporosis, about the etiology, what are the causes, and how do you diagnose and manage a case of the osteoporosis. So let's discuss with the white blank page. So osteoporosis টা হচ্ছে কি, osteoporosis হচ্ছে কি তোমার কি যখনই তোমার bone density টা decrease হয়ে যাবে, when there is a decrease in the bone density, we called it osteoporosis. So osteoporosis, what are the causes? So if you're thinking causes of the osteoporosis, so there are many causes. So primary, it is divided into the primary osteoporosis and the secondary osteoporosis. So primary osteoporosis is so if there is idiopathic, we do not find any cause, idiopathic cause, then we call it primary osteoporosis. When there is secondary osteoporosis, there is any cause associated. So we can remember the cause by the mnemonic of the HINDER, hinder. So H দিয়ে কি আমাদের কোনো inherited H দিয়ে হচ্ছে কি আমাদের hematological causes like leukemia, lymphoma, H দিয়ে I দিয়ে হচ্ছে কি তোমার I দিয়ে হচ্ছে কি আমাদের inherited causes like Marfan, Ehlers-Danlos syndrome, right? N দিয়ে হচ্ছে কি তোমার nutrition like malnutrition, right? Malnutrition and malabsorption, right? D দিয়ে হচ্ছে কি তোমার drugs, such as certain drugs like anticonvulsant drugs, heparin. So these drugs usually associated with the osteoporosis. E দিয়ে হচ্ছে কি তোমার endocrine cause. Endocrine এর মধ্যে আমাদের আছে hyperparathyroidism, right? Hyperparathyroidism. আর তোমার আর দিয়ে হচ্ছে কি rheumatologic cause, any rheumatologic cause like ankylosing spondylitis, rheumatoid arthritis. These are the rheumatologic causes of the osteoporosis. So these are the causes of the osteoporosis. So they can ask you like how can you diagnose the osteoporosis. So diagnosis is a specific test. There is a specific test like the gold standard test for the diagnosis of the osteoporosis is a DEXA scan. DEXA scan. What is DEXA scan? DEXA scan is a dual energy X-ray absorptiometry. The full form is dual energy X-ray absorptiometry. So this is the specific for the osteoporosis. It measures the density of the bone. So if the T-score of the DEXA score falls below or equal to the less than -2.5, then we diagnose this as a case of the osteoporosis. Okay, so osteoporosis is a diagnosis. So how do we manage the case of the osteoporosis? So osteoporosis হচ্ছে কি আমাদের ট্রিটমেন্টে হচ্ছে কি একটা আছে নন ফার্মাকোলজিক্যাল ম্যানেজমেন্ট আর একটা আছে ফার্মাকোলজিক্যাল ম্যানেজমেন্ট. সো এখানে আসো ট্রিটমেন্টে নন ফার্মাকোলজিক্যাল ম্যানেজমেন্টটা হচ্ছে কি তোমার প্রেসিপিটেটিং ফ্যাক্টরটা আমাদের কমাবো। So we decrease the precipitating factors like smoking, alcohol, sedation, right? Then muscle exercise বললে হবে না, এখানে বলতে হবে তোমার কি muscle bearing exercise. So exercise, smoking, alcohol, we are avoiding smoking, alcohol. These are the non-pharmacologic management. Then another আসো কি pharmacologic management. So pharmacologic management কি আছে? So pharmacologic management হচ্ছে কি তুমি you can like differentiate between those that inhibit resorption, that stimulate the formation of the bone. So আমাদের এখানে কি বোনটা লস হইতেছে, right? So we have to stimulate. So stimulate bone formation টা stimulate করার জন্য what we can give the parathyroid, calcium, vitamin D, right? So we can give the calcium supplement, we can give the parathyroid PTH analog. So we have a specific drug here, teriparatide. So this is the drug that we use to stimulate the enhancement of the bone, formation of the bone. So this is pharmacologic management that stimulate the bone formation. Another one is inhibit resorption. So inhibit resorption inhibit করার জন্য আমরা কি ইউজ করতে পারবো? We have one drug that we commonly use, the bisphosphonate drug, bisphosphonate, and another one is calcitonin, that is vitamin D, the hormone that is released from the parathyroid, that is the hormone, endocrine hormone. Then another one, you come to there is a monoclonal antibody that is called denosumab. That is one monoclonal antibody we use, denosumab. Another one you can see is estrogen. Stimulate the bone, inhibit the bone resorption. Okay, so you can remember is that by the mnemonic of the ABCD. BDK হচ্ছে কি bisphosphonate, CD হচ্ছে calcitonin, DD হচ্ছে denosumab, একটা আমাদের monoclonal antibody, আর একটা আছে কি আমাদের estrogen, E দিয়ে হচ্ছে কি estrogen, A দিয়ে কিছু নাই, A দিয়ে মনে করো absence, B দিয়ে bisphosphonate, calcitonin, denosumab and estrogen, BCDE. So mnemonic টা কি BCDE. So that inhibit the resorption of the bone. So non-pharmacologic, pharmacologic, এটা হয়ে গেল, right? So এখন আসো ম্যানেজমেন্ট প্ল্যান হয়ে গেল। সো অস্টিওপোরোসিসটা শেষ। এখন আসো আমাদের যাব এখন we go for the seronegative and seropositive arthritis part. So we'll discuss about the seronegative and seropositive. So seropositive হচ্ছে কি তোমার কি rheumatoid arthritis আর SLE, আর seronegative হচ্ছে কি আমাদের ওই চারটা, reactive arthritis, ankylosing spondylitis, enteropathic and psoriatic arthritis. So rheumatoid arthritis থেকে দেখো আমাদের কোয়েশ্চেনটা করা আছে কি করা আছে, we have a criteria টা জিজ্ঞেস করা আছে, hand deformities, biological drugs use, 3 screening and confirmatory test, DOMARDs মানে disease modifying anti rheumatic drugs গুলা. So ankylosing, so seronegative তে হচ্ছে কি আমাদের ইম্পর্টেন্টটা হচ্ছে কি ankylosing spondylitis and the reactive arthritis. So এখন আসো সেরোপজিটিভের মধ্যে আমরা বলবো rheumatoid arthritis. So this is seropositive arthritis. So seropositive arthritis, why it is seropositive arthritis? So it is usually the blood is positive for the rheumatoid factor positive. Okay, so that's why we call this as a seropositive arthritis. So you can say what is rheumatoid factor, right? So rheumatoid factor is the IgM antibody against the FC portion of the IgG. Okay, remember rheumatoid factor is the IgM antibody against the FC portion of the IgG antibody, right? So this is the rheumatoid factor. So whenever the rheumatoid factor is positive, we call it seropositive arthritis. Okay, so rheumatoid arthritis has like the characteristic of the exacerbating and remitting features, like suddenly it will exacerbate and the patient will go under the remission, like that the patient will suffer like this. And then as a clinical feature key, rheumatoid factor, usually the patient will present as a polyarthritis. As we have already discussed, when you think about polyarthritis, you think of the 3 things: rheumatoid arthritis, SLE, viral arthritis. So patient কি নিয়ে আসবে? polyarthritis নিয়ে আসবে। So patient থাকবে small joint mainly involved থাকবে। So it is an inflammatory arthritis. As it is inflammatory arthritis, so it is worse in the morning and improves on exercise. So the main important thing here is hand deformities. Rheumatoid arthritis, hand deformities almost always invariably asked. So একটা ইম্পর্টেন্ট জিনিসটা হচ্ছে কি রিউমাটয়েড আর্থ্রাইটিসের ক্যারেক্টারিস্টিক ফিচারটা হচ্ছে কি ডিস্টাল ইন্টারফ্যালাঞ্জিয়াল জয়েন্টটা এটা কখনো ইনভলভ করবে না, এটা অলওয়েজ স্পেয়ারস দি ডিস্টাল ইন্টারফ্যালাঞ্জিয়াল জয়েন্ট। সো রিমেম্বার দিস। এখন আসো আলনার ড্রিফট থাকবে। এখন আলনার ড্রিফট মানে দেখো আলনার দিকে মানে হাতটা যাইতেছে। আরেকটা আছে বোটোনিয়ার ডিফর্মিটি অ্যান্ড সোয়ানেট ডিফর্মিটি। বোটোনিয়ার ডিফর্মিটিটা হচ্ছে কি এরকম, হাতটা এরকম। সোয়ান নেকটা হচ্ছে কি তোমার ডিস্টাল দিস ইজ নট দ্য ডিস্টাল interphalangeal joint involvement, okay, there is a tendon involvement that causes the features of the swan neck deformity. All right, another also jet deformity of the thumb bole. So whenever there is a hyperextension of the interphalangeal joint, as you can appreciate, here is a formation of the jet like shape, so that is the jet deformity of the thumb. So this is another feature. So the now let's move on to the extra-articular manifestation of the rheumatoid arthritis. So whenever you like study for the extra-articular manifestation of the rheumatoid arthritis, you also like the compare side by side with this SLE. So it is easier for you to memorize. So I'm giving this slide because the main point I want to tell you that rheumatoid arthritis and the SLE, the extra-articular features should be studied in the same manner, you know, side by side, so you can remember. So ekhane aso ekta aso Felty syndrome bole ekta jinis ase. So what is Felty syndrome? Whenever the patient, rheumatoid arthritis patient, has neutropenia and splenomegaly, this triad is called the Felty syndrome. What is it? This triad, right? Triad is the Felty syndrome. This is asked in the Viva, all right? So you have to remember this. So ekhon aso suppose the patient of the rheumatoid arthritis patient has the sudden sudden death. What is the cause of the sudden death in the rheumatoid arthritis? They can ask about this, right? So the causes of the sudden death in the rheumatoid arthritis is what? If you're guessing subluxation of the atlantoaxial joint and ischemic heart disease, you're right. So what happens in the rheumatoid arthritis is there is a subluxation of the atlantoaxial joint, that is the part with the atlas and axis, right? So if there is a subluxation, it will compress the like the medulla centers and the major vital centers, that will cause the sudden death. Another one is the ischemic heart disease. There is a coronary vasculitis associated with it, so that causes the sudden death. Also, the criteria for diagnosis of the rheumatoid arthritis, this is the ELAR criteria, that is European League Against Rheumatism or American College of Rheumatology, ACRO bole, ELARO bole. So you can remember it by the mnemonic JSAD. So what is the mnemonic? JSAD. J di hoche ki joint affected. Another one is the serology. A di hoche acute phase reactant, D di hoche duration. So I want so you will learn about this, but I want to mainly point out the important things here. So whenever the patient has involvement of the small joints, so small joints involvement বেশি থাকলে they will get a score bigger numbers. দেখো এখানে 4 to 10 small joints এই পাওয়া গেছে পেশেন্টটা কি আমাদের 3 score পাওয়া গেছে. So usually think about the low, like the small joints in the rheumatoid arthritis. So serology হচ্ছে তোমার নেগেটিভ rheumatoid factor আর anti-citrullinated peptide antibody. দেখো এখানে দুইটা আছে আমাদের rheumatoid factor. So rheumatoid factor is the most sensitive, okay, it is sensitive but not specific. But the anti-citrullinated peptide antibody, this antibody is the specific, okay, specific for the rheumatoid arthritis. Remember this. So duration এটা তোমরা পড়বা, কিন্তু remember small joints বেশি পাবে, আর remember with the JSAD mnemonic. এখন আসো ইনভেস্টিগেশন কি কি করব? ইনভেস্টিগেশন তো সিবিসি, উই রুটিন ইনভেস্টিগেশন, সিবিসি তে অ্যানিমিয়া পাবো, রাইট, রেজিয়াস পাবো, এগুলো ঠিক আছে. What is the most sensitive test? Most sensitive factor. And they can ask you what is the most specific test? That is the anti-citrullinated peptide antibody. So this is important. X-ray the bone erosion, egula joint space narrowing, usually the periarticle is osteopenia, egulai pabo amra. So treatment. So rheumatoid arthritis treatment is multidisciplinary approach, not only the rheumatologist but also the orthopedicians, also the physical medicine department. All right, so the treatment here is like when the patient is like the patient comes first, we give usually the symptomatic treatment is with the NSAIDs and the COX-2 inhibitor like the celecoxib. And the first thing, like the first therapy we use is the triple therapy. And triple therapy, there is 3 drugs, as you know, methotrexate, sulfasalazine, and hydroxychloroquine. All right. So this triple therapy like takes time to work. It usually takes time 4 to 12 weeks to work. So patient নিতেছে কি 4 to 12 weeks লাগতেছে কাজ করার জন্য. So that's why so acute phase আমরা কি মানে এখনি মানে কাজ করতে জন্য আমরা কি দিব, that's why we give the glucocorticosteroid. Okay, so in the meantime we give glucocorticosteroid to act. Okay, so if the triple therapy does not work, we add the biologics to the methotrexate. Methotrexate এর সাথে সাথে আমরা কি biologics start করব, or we have another regimen, that is methotrexate plus new. This is the new regimen. All right, this is JAK2 inhibitor, that is tofacitinib and baricitinib. So what are the disease modifying anti-rheumatic drugs? Disease DMARD kiki, DMARD kiki ase ar ota side effect kiki eta tomarke jigesh korbe. So we usually have to give treatment with the methotrexate, hydroxychloroquine, and sulfasalazine, right? Let me first discuss this first. So methotrexate, so one complication, like the one main side effect, it is hepatotoxic. Okay, the methotrexate is hepatotoxic drug, so we have to give liver enzymes every 4 to 6 weekly. So another adverse effect is also cytopenias. It decreases the blood levels of the cells. So we also have to do the CBC levels. Okay, these two are the main complications of the methotrexate. And hydroxychloroquine, main complication is the retinopathy. So I'm discussing the main complication here. Okay, so I'm not discussing about the nausea, vomiting part. You know, all the drugs causes nausea, vomit, but the specific for the hydroxychloroquine is the retinopathy. And for the cases of the sulfasalazine is hepatotoxic also, and it is usually associated with granulocytosis. A granulocytosis means what? There is a decrease in granulocytes in the blood. Granulocytes decrease of it. So that's why the patients will present as a sore throat, man, infectious disease, infectious feature infection feature like sore throat, fever, egula patient. So hepatotoxicity, granulocytosis, hemolytic anemias, these are the side effects of the sulfasalazine. So what are the biologics, commonly used biologics? So in like Viva or written, they will ask about what are the commonly used biologics. So you can say adalimumab, golimumab, infliximab, etanercept, right? So they will ask like, what is the complication? What are the adverse effects? So they usually work by inhibiting the immune suppression, right? So patient is increased risk of the infection. There can be an increased risk of the demyelination, right? Patient can also develop the malignancy, and some drugs are the cardiotoxic, and the patient can develop the congestive cardiac failure. So these are the drugs, right? So this is the harsh reality, you know. During my medical student, like when I was a medical student, always we used to like, so this is the rare picture of the medical student assisting in surgery in OD. So now let's move on to the seronegative spondyloarthritis. So seronegative means what? We have the negative for the rheumatoid factor negative থাকবে, তাই জন্য আমরা বলতেছি কি seronegative. So seronegative মধ্যে আগে ছিল 4টা. So previously there was only the 4, that is reactive arthritis, ankylosing spondylitis, psoriatic arthritis, and enteropathic arthritis. But now the new term has been added. Newly added term is axial spondyloarthritis. So this is the beginning phase of the seronegative spondyloarthritis, and this spondyloarthritis is usually you have to do the MRI to diagnose this. So just remember, this is newly added, and you have to do the MRI for the diagnosis, right? And you can remember by the mnemonic RAP, Repte Monoarthritis. So one question is, what are the common features of the seronegative spondyloarthritis? So seronegative spondyloarthritis has the asymmetric inflammatory oligoarthritis, that is involvement of the 2 to 4 joint groups, right? And there is inflammatory back pain, there is sacroiliitis, family history থাকবে, HLA-B27. So this is important, HLA-B27 positive থাকবে, enthesitis. So what is enthesitis? Enthesitis টা হচ্ছে whenever the tendon is inserting into insertion তোমার যখনই inflammation হয়ে যাবে, we call this enthesitis. So enthesitis is usually like it is seen in the tendo-Achilles part, right? The patient will complains of the heel pain, right? So another one is the extra-articular manifestation. What are the extra-articular manifestation? So patient can have the sterile urethritis, prostatitis, uveitis, aortic regurgitation, psoriasis, IBD, right? These are the extra-articular manifestation, like sterile arthritis and prostatitis usually associated with the reactive arthritis, uveitis, ankylosing spondylitis, uveitis আর aortic regurgitation পাওয়া যায়, সোরিয়াসিসটা হচ্ছে তোমার সোরিয়াট্রিক আর্থ্রাইটিসে পাওয়া যায়, আইবিটা হচ্ছে ইন্টেরোপ্যাথিকে পাওয়া যায়, রাইট? এখন আসো ankylosing spondylitis. So what is ankylosing spondylitis? And spondylitis মানে কি? Spondylitis হচ্ছে কি inflammation, okay? This is the inflammation. And then other terms like the similar terms we like they use is spondylosis, spondylitis, and spondylolisthesis. So spondylosis means, like we commonly use the term cervical spondylosis. So it means there is a degeneration of the cervical spine. So spondylosis হচ্ছে কি degeneration of the cervical spine. আরেকটা আছে spondylolysis. So lysis, there is a defect in the pars articularis between the two vertebrae. So that is spondylolysis. Then another one is spondylolisthesis. Another one is a listhesis. There is an anterior slip of the vertebra. The vertebra, একটা vertebra উপরে আরেকটা vertebra slip হয়ে যায়, anterior slip হয়ে যাইলে we call it spondylolisthesis. এখন আসো how the ankylosing spondylitis presents. Like it usually presents oligoarthritis in a young male patients. There is a morning stiffness and that improves on exercise, like the inflammatory arthritis features. So important one is what are the extra spinal features that the ankylosing spondylitis has. The extra, like the most common one is the anterior uveitis. Okay, the patient will say that red eye patient red eye থাকবে. So that is most common one is anterior uveitis. Other one is like the enthesitis, that is inflammation of the tendon insertion জায়গাতে inflammation হয়ে গেল, আর dactylitis. So dactylitis হচ্ছে swelling থাকবে, তোমার ফিঙ্গারে swelling থাকবে, that is also called a saucer's finger, and also the aortic regurgitation. So sign. So how do you diagnose, like this patient has a like the ankylosing spondylitis clinically? So clinically we can look for the lower back এর মধ্যে আমরা কি দেখতে পারবো? We can look for the any restriction of the movement, right? So we do it by the modified Sobar test, which is positive in this case. So এটা হচ্ছে কি আমাদের এখানে দেখো ডিম্পল, একটা ডিম্পল থাকে পিছনে। সো ওই ডিম্পল দেখে উপরে আমরা 10 সেন্টিমিটার উপরে একটা লাইন দিই, আর ওই যে ডিম্পল দিয়ে 5 সেন্টিমিটার আমরা নিচে একটা লাইন দিই। সো টোটালটা হয়ে গেল কি 15 সেন্টিমিটার, রাইট? সো এটা 15, আর পেশেন্টে বলবো এখন কি ফ্লেক্সন করার জন্য। পেশেন্টটা কি করবে? ফ্লেক্সন করবে। ফ্লেক্সন করার পরে নর্মালি ইট শুড বি গ্রেটার দ্যান 21, দ্যাট ইজ নর্মালি পেশেন্টের 6 সেন্টিমিটারের উপরে, মানে পেশেন্টে কি আমাদের মানে ফ্লেক্সন থাকতে হবে, মানে এটা ইনক্রিজ হইতে হবে আমাদের কি লেন্থটা। ইফ ইট ইজ লেস দেন মানে মানে হইল না, মানে ইফ ইট ইজ লেস দেন 21 সেন্টিমিটার, দেন উই কলড ইট there is a restriction, that is modified Sobar test positive. Okay, এখন আসলে ইনভেস্টিগেশনের মধ্যে most commonly it is 90%, 80 to 90% patient is SLA-B27 positive, and the ESR and CRP is raised as it is an inflammatory arthritis. And the main important diagnostic finding here is the X-ray finding. So we can appreciate the three features. One is bamboo spine, another one is dagger sign, another one is trolley track sign. So we're gonna discuss this. So investigation of choice will be MRI. So we're gonna look at the X-ray. So bamboo spine টা কি? এখন দেখো এখানে দেখো কি ব্যাম্বো তোমাকে দেখতেছে, right? So as you can see this vertebra, so it is looking like the bamboo. Why it is looking like a bamboo? Because there is a complete fusion of the vertebral bodies. So ওখানে fusion of the vertebral bodies আছে, ওখানে bridging syndesmophytes গুলো আছে, মানে কোনো joint space নাই, ওখানে bridging syndesmophytes আছে। Then there is a loss of, এখানে দেখো anterior concavity থাকে, একটা ভার্টিব্রা হইতে হলে এরকম থাকে ভার্টিব্রাটা। সো এটা অ্যান্টেরিয়র কনকেভিটি বা লস হয়ে কি হয়ে যাবে, এখানে এরকম স্ট্রেট হয়ে যাবে। স্কোয়ারিং অফ দ্য ভার্টিব্রাল বডিজ বলে এটাকে, স্কোয়ারিং অফ দ্য ভার্টিব্রাল বডিজ, অলরাইট? সো স্কোয়ারিং অফ দ্য ভার্টিব্রাল বডিজ থাকবে। সো দিস ইজ হাউ উই ক্যান লাইক দি say that this is the bamboo spine. So bamboo spine is a combination of the features. Okay, another one is a dagger sign. Dagger মানে হচ্ছে কি একটা এরকম সোর্ডের মতো। সো ড্যাগার সাইন মানে কি? সো ড্যাগার সাইন মানে মাঝখানে একটা তোমার কি ওসিফিকেশনটা দেখা যাবে। So what is this ossification? This ossification is the ligamental ossification. It is the interspinous ligamenta ossify হয়ে গেছে. So this is the dagger sign. Then another one, trolley track sign. Trolley track সাইনটা কি, মাঝখানে ড্যাগার মতো, দেখো এখানে ট্র্যাকের মতো, মানে রেলের ট্র্যাক মতো, মাঝখানেও থাকবে, সাইডে দুইটাও কি আমাদের একটা ওসিফিকেশনটা থাকবে। সো এখানে ইউ ক্যান অ্যাপ্রিশিয়েট ইন দিস পিকচার, মাঝখানে একটা ট্রলি ট্র্যাকের মতো, মানে মাঝখানে একটা আছে আর দুই পাশে ওসিফিকেশন লাইনটা আছে। সো সেন্ট্রাল ভার্টিক্যাল লাইনটা হচ্ছে স্পাইন ইন্টারস্পাইনাস লাইনে ওসিফিকেশনের কারণে, আর তোমার পেরিফেরালি দুইটা যে ভার্টিক্যাল লাইন আছে ওটা হচ্ছে কি তোমার অ্যাপোফাইসিয়াল, তোমার তোমার জয়েন্ট ক্যাপসুল, অ্যাপোফাইসিয়াল জয়েন্ট ক্যাপসুলটা তোমার ওসিফিকেশন হওয়ার কারণে সাইড সাইডে দুইটা ভার্টিক্যাল লাইনটা দেখা যাবে। সো this is trolley track sign. Now let's move on to the treatment. So treatment এর মধ্যে হচ্ছে কি তোমার main thing is in ankylosing spondylitis is physical therapy. Patient should go, there is a no cure, okay? So cure নাই এই disease, so there is cure নাই, no cure. We have to give the physical therapy and the drugs. Midline axial disease, usually drugs are more effective, like biologics drug like infliximab, adalimumab. These are the effective drugs. So, and for the pain we give the NSAIDs, and if there is a surgery, if the patient is candidate for the surgery, if there is a severe hip or knee restriction, then we can do the surgery. Okay, now let's move on to the another topic, reactive arthritis. So reactive arthritis ta hocche ki eta has a complication hisabe asbe. So not, it is a not like the ekhuni asbe na, mane infection pe 3 weeks pore. So suppose the patient had like the Campylobacter diarrhea, and after the 3 weeks patient developed the features of the tinta features develop korbe. Okay, remember with the can't pee, can't see and can't climb the tree. Can't see mane hocche ki conjunctivitis, can't pee mane hocche ki non gonococcal urethritis, can't climb the tree mane hocche ki arthritis. So these are the features of the triad of the reactive arthritis. So usually complication, usually the amade reactive arthritis after Shigella, Yersinia, Chlamydia, Campylobacter or Salmonella infection they have. So you can remember with the mnemonic of Psychics. So this is the mnemonic I like to remember. Then also amade ekhon aso what are the other features? So তোমার রিঅ্যাক্টিভ আর্থ্রাইটিসে অন্যগুলা ফিচার কি কি থাকতে পারে, এগুলা ছাড়া, মানে এই যে ট্রায়াড ছাড়া আমাদের ইনথেসাইটিস আছে, আরেকটা আছে সার্সিনেট ব্যালানাইটিস। সার্সিনেট ব্যালানাইটিসটা হচ্ছে কি তোমার গ্ল্যান্সে ইনফেকশনে বলে আমরা কি সার্সিনেট ব্যালানাইটিস, মানে হচ্ছে আমাদের কি গ্ল্যান্স ইনফ্লামেশন অফ দ্য গ্ল্যান্স পেনিস। আরেকটা আছে কেরাটোডার্মা ব্লেনোরেজিকা, ইম্পর্টেন্ট ওয়ান, রাইট? সো আইল শো ইউ figure. So see here, you can see the vesicopapules, right? You can see papules, right, arising, and there is some vesicles with the desquamation, desquamous lesion. You can see here, you can see the desquamous lesion of the palm and sole. This is called the keratoderma blenorrhezica. This is the feature of the reactive arthritis. Now the investigation, there is no any like the diagnostic test for the reactive arthritis. Usually we do the x-ray of the affected joint, like we find the arthritis, there is ESR and CRP. So it is usually diagnosed as a basis on the clinical criteria. So treatment হচ্ছে কি তোমার first line treatment হচ্ছে কি rest and NSAIDs. So NSAID হচ্ছে কি তোমার first line treatment is NSAIDs. If the patient is having a persistent symptoms, like if not controlled, then we can use the disease modifying anti-rheumatic drugs. If not controlled, we can go for the anti-TNF therapy to make biologics jaite paru. And there has been studies that the tetracycline has been shown to be the effective in case of the non-specific chlamydial urethritis. So chlamydial cause the oile amader ki tetracycline, short term course with the tetracycline is shown to be the effective. So ekhon aso, if you know the answer, you can write in the chat section. So what is the diagnosis, if you can diagnose these cases? So a 20-year-old man presents to you with a low back pain and morning stiffness. Okay, morning stiffness as a low back pain as a, and there was also a knee and ankle swelling for 8 weeks. 8 weeks is ankle swelling chilo. The symptoms were aggravated by inactivity and relieved by movement. দেখো এখানে 20 years old male patient has like complaining low back pain that increases on inactivity and relieved by movement. So what do you think? So anyone, if there any answer in that? So all right, there is no answer. So this is a case of the ankylosing spondylitis. Okay, so why this is ankylosing spondylitis? First thing, look at here. It is saying male patient. Okay, so male patient common টা হচ্ছে কি আমাদের এখানে not very much rheumatologic disease বেশি আসে না আমাদের মেলে কমন। সো আমাদের আর্থ্রাইটিস লাইক সেরোপজিটিভ অ্যান্ড সেরোনেগেটিভ আর্থ্রাইটিস দিয়ে আমাদের মেইন কমন জিনিস মেলে কমন হচ্ছে কি অ্যানকাইলোজিং স্পন্ডিলাইটিস অ্যান্ড রিয়াক্টিভ আর্থ্রাইটিস, এই দুইটা জিনিস হচ্ছে কি আমাদের কমন ইন মেল। সো এখানে দেখো lower back pain and morning stiffness. Lower back pain, usually the ankylosing spondylitis has the lower back pain feature নিয়ে আসবে। আর পেশেন্টটা হচ্ছে কি এখানে দেখো পেশেন্টটা osteoarthritis feature নিয়ে আসে, নি অ্যান্ড অ্যাঙ্কেলও আসে, not more than 3 joints involvement আসে এখানে আসে নেই। সো inflammatory features, it is the ankylosing spondylitis। এখন আসো question number 2 দেখো। Question number 2, 20 years old man has red eyes, swelling of the right knee, ankle and tarsal joint. He has history of the bacillary dysentery 2 weeks back. So bacillary dysentery 2 weeks back. After 2 weeks, the patient develops conjunctivitis, arthritis, right? So, arthritis. So what it is, I told you about this. So after infection, 2 to 3 weeks of infection, the patient will have the reactive arthritis, right? So the reactive arthritis is the answer here. So this is the reactive arthritis. So question number 3, देखो 30-year-old lady presented with the polyarthritis of the hands, knee, ankle joint for 6 months with morning stiffness, likely that. So polyarthritis, three diagnoses you in your mind. One is rheumatoid arthritis, another one is SLE, and another one is viral arthritis. So it can be any of those. Okay. So this is a quote, exam will be nice to you if you will be nice to your studies, right? This is the reality. So we don't prepare well, it will be difficult, exam will be difficult for us. So now we'll discuss about last topic today. Here is SLE, systemic lupus erythematosus. So SLE, usually SLE patient features টা কি হবে, usually a female patient কি নিয়ে আসবে, female patient তোমার butterfly rash in the cheeks, right? There is a history of arthritis, এগুলো ফিচার নিয়ে আসলে আমরা কি চিন্তা করব, this is a case of SLE. So they can ask you like, how can you diagnose, what is the diagnostic criteria for SLE? So SLE diagnostic criteria জন্য we have the diagnostic criteria. So diagnostic criteria, we have a mnemonic, we can remember it by the mnemonic. Mnemonic নামটা কি, mnemonic এর নাম হচ্ছে কি MD soap brain. So let me talk to you about the mnemonic. Mnemonic হচ্ছে কি MD SOAP soap BRAIN brain. So MD soap brain হচ্ছে কি mnemonic. M দিয়ে কি, M দিয়ে হচ্ছে malar rash, M দিয়ে হচ্ছে কি malar rash, M দিয়ে malar rash, আর D দিয়ে হচ্ছে কি discoid rash, S দিয়ে হচ্ছে কি serositis, any like pleuritis, these things, serositis. O দিয়ে হচ্ছে কি তোমার, O দিয়ে হচ্ছে কি oral ulcers, A দিয়ে হচ্ছে কি arthritis. Okay, P দিয়ে হচ্ছে কি তোমার, P দিয়ে হচ্ছে কি তোমার any আমাদের photosensitivity, like the patient will have the butterfly rash after sun exposure, P দিয়ে হচ্ছে photosensitivity. B দিয়ে হচ্ছে কি ব্লাডে আমাদের তিনটাই জিনিস কম থাকে, লাইক উই ক্যান হ্যাভ অ্যানিমিয়া, ডব্লিউবিসি কম থাকতে পারে, প্লেটলেটসও কম থাকতে পারে। আর দিয়ে হচ্ছে কি রেনালের মধ্যে আমাদের রেনাল ইনভলভমেন্টও থাকতে পারে, পেশেন্ট ক্যান ডেভেলপ হেমাচুরিয়া। বি আর এ দিয়ে হচ্ছে কি এএনএ, পেশেন্ট উইল হ্যাভ এএনএ পজিটিভ, অ্যান্টি নিউট্রোফিলিক অ্যান্টিবডি পজিটিভ। আই দিয়ে হচ্ছে কি ইমিউনোলজিক, এনি আদার ইমিউনোলজিক কি আছে আমাদের ডবল স্ট্যান্ডার্ড অ্যান্টিবডিজ আছে। অ্যান্ড দিয়ে হচ্ছে কি নিউরোলজিক্যাল ফিচার লাইক সাইকিয়াট্রিক ফিচারও থাকতে পারে পেশেন্ট। অলরাইট, সো দিস ইজ দি ডায়াগনস্টিক ক্রাইটেরিয়া ফর দি সিস্টেমিক লুপাস এরিথেমাটোসিস। So here they can ask about what are the investigation you will do for the SLE. So SLE মধ্যে don't ever write CBC and that kind of thing first, right? So CBC দিয়ে ESR CRP দিয়ে আমরা মানে ডায়াগনোসিস করতে পারবো না, we have to write about the specific things first. So specific thing হচ্ছে কি অ্যান্টিবডিজ গুলা। So most sensitive টেস্টটা হচ্ছে কি ANA most sensitive. So most sensitive টেস্টটা হচ্ছে কি anti neutrophilic antibody, okay? anti-nuclear antibodies are most sensitive গুলা হচ্ছে কি sensitive হচ্ছে anti double stranded DNA antibodies and anti-phospholipid antibody. So first write these three antibodies first, the markers first. Then another thing you have to like keep in mind, the important one is the thinking about the CRP, the serum complement level. So the thing with the the one thing is, in the active disease of the systemic lupus erythematosus, there is a consumption of the serum complement. So the serum complement level is a marker for the active infection. So serum complement it will decrease in the active phase. So it is the marker for the active phase, remember. And others are the ESR CRP can be raised, right? CBC মতে আমাদের anemia থাকতে পারে. Others are the like the supportive investigation. These are the specific. So how will you treat a case of the SLE? So এখন treatment is right. So treatment of SLE. So treatment of SLE is, there is no cure, okay? So there is a no cure. Cure bolte kyun nahi. So you are minimizing symptoms, supportive treatment dite, so that's all. There is a no cure, right? Okay, so cure nahi. So তাহলে এখন আসো আমাদের কি থেরাপিউটিক মানে পেশেন্টটা কি হবে, আমাদের কি পেশেন্টের জন্য কি কাউন্সেলিং করা লাগবে, মেইনলি তো কাউন্সেলিং করা লাগবে। দেন another thing is পেশেন্টে মানে ফটো সেন্সিটিভিটি এগুলা ডেভেলপ করে, তাই জন্য আমরা কি করব, পেশেন্টে মানে বলবো কি অ্যাভয়েড সান এক্সপোজার, মানে প্রোটেক্টিভ ক্লথিং গুলা নিয়ে আসলে, মানে অ্যাভয়েডিং সান এক্সপোজার অর প্রোটেক্টিভ ক্লোথিং এগুলা ওয়্যার করার জন্য বলবো, রাইট? এখন আসো mild to moderate disease আছে, so there is no any like the severe feature or no the patient does not have acute flare, ওই সময় আমরা কি করব? So suppose the patient is having mild flare, then we can give for the arthritis part. So patient will, if there is arthritis, we can give NSAIDs dite parbo. And if the patient is having skin problems, like there is a photosensitivity, then we can give corticosteroid. Corticosteroid, my locally giving corticosteroid ta dite parbo mildly. এখন আসো পেশেন্টটা ডেভেলপ করছে acute মানে পেশেন্টটা এখন অ্যাকিউট ফ্লেয়ার নিয়ে আসছে, ওটা কিভাবে ম্যানেজ করব? সো অ্যাকিউট ফ্লেয়ারের জন্য আমরা কিভাবে ম্যানেজ করি, এখন মানে হচ্ছে কি এখনই দিতে হবে আমাদের কি corticosteroids and immunosuppression. So we usually use the methylprednisolone plus cyclophosphamide. So for the maintenance part, we give what? This is the first thing, like acute flare নিয়ে আসলে আমরা prednisolone, corticosteroid and একটা immunosuppression start করব, and maintenance এর জন্য আমরা prednisolone তো রাখবোই, so we'll keep the prednisolone. Side by side we can give the azathioprine and other drugs, so other maintenance drug as azathioprine and mycophenolate. These are the drugs we can also prescribe as a maintenance therapy, okay? And then also এখানে একটা important জিনিস আছে, so এখানে দেখো the patient is complaining of the repeated abortion. So একটা তো হচ্ছে SLE ট্রিটমেন্ট দিছি আমরা, আরেকটা হচ্ছে কি আমাদের রিপিটেড অ্যাবর্শনের জন্য আমরা কি ট্রিটমেন্ট দিতে পারি, মানে পরবর্তী নেক্সট মানে আমরা যে হইতেছে নেক্সট ও কনসিভ করবে ওই যে ফিমেল, তখন সময় আমরা রিকারেন্ট লস, প্রেগনেন্সি লসটা প্রিভেন্ট করার জন্য আমরা স্টার্ট করতে পারবো লো মলিকুলার ওয়েট হেপারিন। So we'll give low molecular weight heparin during pregnancy. This is important, right? This is important, guys. So why we use the low molecular weight heparin? So দেখা গেছে কি আমাদের এসএলই পেশেন্টে অ্যান্টিফসফোলিপিড সিনড্রোম ডেভেলপ করে। সো অ্যান্টিফসফোলিপিড সিনড্রোম ডেভেলপ করার পরে there is a placental thrombosis হয়ে যায়, মানে প্লাসেন্টার মধ্যে থ্রোম্বোসিস হয়ে যায়, or there is a recurrent pregnancy loss. So to prevent this placental thrombosis, we give the low molecular weight heparin, which prevents the recurrent pregnancy loss. So this is about the SLE. So এখন আসো rheumatoid arthritis আর SLE clinically কিভাবে differentiate করা যায়। So देखो SLE টা typical feature নিয়ে আসবে, like malar rash, discoid rash, there is a photosensitivity, right? There may be a neurological symptoms like psychiatric symptoms. This is the feature of the SLE. So rheumatoid arthritis টা কি নিয়ে আসবে তোমার, usually arthritis features like and the hand deformities টা থাকবে, like the bottleneck deformity, swan neck deformity, jet মানে ulnar deviation, jet deformity of the thumb, right? This features গুলো নিয়ে আসবে, আর পেশেন্টের rheumatoid nodules গুলাও থাকতে পারে। So this is how you can differentiate between the rheumatoid arthritis and SLE. Okay, so that's it for today. So this is all about all questions from the musculoskeletal system part. So hopefully we can start our next system from in the next class, and up to then take care, and if you have any question, please let me know in the comment section. I'll try to answer all of those. So up to then, so take care.